to you and just very relevant for you to see the entire picture of a community health center's revenue sources and not just maybe one component that you're involved in. So the agenda today will focus on how the community health centers generate revenue, the different types of sources of revenue, and payments, which are two different things, and I'll discuss those for you, and also the impact of the ACA on the community revenue, and then what the revenue cycle is, what staff are involved in the revenue cycle. I'm going to give you a best practice of a clinic that is an example of doing a good job with their revenue cycle. And then I'll discuss your patient experience and your revenue cycle, which a lot of times we don't coordinate those two, but they become much more important now, especially inside of ACA. And then we'll discuss the 330 programmatic requirements and the impact of the revenue cycle on those. And then I've also provided you with some sample costs, measures, and reports to monitor, and given you a list of those. And then our last 10 item, number 10, we've got some bonus slides to go through on how to develop a both patient revenue cycle and patient-centered experience program for your community health center. So with that, is the sound all good? Do you want to do any other check, Christina, or do I just go ahead and move along?
Well, your voice faded just a little.
Okay, it is this little speaker here. All right, is that better?
That's better. Thank you, Lucy.
Great. Thank you so much again to everyone, and welcome. So with that, we'll start. On your screen, what you'll see is the first little slide that basically talks about generating revenue for community centers. And like I said, there's revenue sources, and there's also payment sources. So I'll be going through those differences. The revenue is what may be generated, but the payments are a different source. They don't always go hand in hand. So for every dollar that you generate in a community clinic, it does not mean that you get paid that same dollar. So that's the two differences between both the revenue versus payments. And so with the community centers, there's obviously a number of different sources, and patients being your primary. Then there's also grant revenue, there's donations, there's incentives, and there's other revenue that can be generated. So we're going to go through real quick each of these to give you an idea of what they look like. So for patients, those patient payment sources could consist of self-pay, which of course a lot of you are all familiar with. That's tied to your sliding fee primarily. Medicaid, in some states, Medi-Cal, and your Medicare payer source. There's other public insurance payments, and there's private insurance payments, and then of course there's also indigent care programs in some of your states. Those are very specific to your specific state. So that's, from the patient's perspective, that can be any of those type of source of payments that a patient can generate. And then of course, as a community clinic, you receive payment for Medicaid and Medicare in two forms. And the first two forms, your Medicaid is what's called the prospective payment system rate, your PPS rate. And then for your Medicare, there's a Medicare cost report, and now there's also a new average rate that Medicaid has started this coming November here for you. Some of you are phasing into that. But that's a blended rate that they've come up with now that's adjusted for you. But you still have cost report, and it is based on average costs for the entire Medicare population that community health centers have served. And then, of course, your other public payer could be on a fee-for-service. So, in other words, it's paid per visit, just as your Medicaid may be and your Medicare is, except for the rate is usually a negotiated rate based on a contract. And then you could also have what is called capitated rates, or PMs. That's per member per month. And what that really means is that you're getting paid a flat amount to see that patient, whether you see the patient or not. It's usually a smallish amount per each one. And that patient could come in one time, or that patient could come in 15 times. The average, depending on the age of the patient, for pediatric can be anywhere between 5 and well, actually, patient, if it's pediatric, about 5 but to 6, and for your adult population, it's more between 3 to 4 And then for your Medicaid population, for your PPS rate, the other thing that would happen in certain states is that you'd have a reconciliation at the end of the year. Some do it on a quarterly basis. Each state is slightly different. And there, where you have a patient that has a straight Medicaid coverage, and that coverage is through an private insurance company, so they've contracted with a managed care company, you're still getting paid per visit, but you'd be getting a different amount, usually typically a smaller amount, and then you're having to collect the difference from the actual state, and that's what's called the PPS reconciliation. And again, because we've got a whole variety of different states represented here, each one of you is going to be slightly different. But this gives you an idea of how those payments actually occur for the community center. And of course, this is complex. So with that, I'm going to go to the next source of revenue that you have at community health centers, and that's grants. And typically what a grant is, it's someone else's mission that they give you money to accomplish. And some grants, of course, can be very much in line with your mission, and some may not be, and it can be beneficial, or they can be costly. So grants have to really sort of be evaluated based on a variety of criteria. But typically in community health centers, what we see is your 330 funding. Of course, that's your primary, and that's where the FQHCs and FQHC lookalikes, even though they don't get the funding, they still have the requirement. And then there's other federal grants that you may receive, expanded access, that are also through the federal funding, or capital grants, those types of things. But you also have a large portion of state and local grants. And then, of course, a smaller amount of private and foundation grants. And, of course, the 330 federal grant funding does have the 19 program requirements that you have to comply with. So you're basically saying to the federal government, if I'm going to receive these funds from you, I'm going to make sure that as a community health center, I'm going to comply with these 19 program requirements, which probably most of you are very familiar with. But if you're not, we'll go through some of those that are impacted by the revenue cycle a little later. And so, like I said, grants are not always free money. There's always strings attached, and there is compliance requirements, and they're very important to ensure that you're complying with those, since that is federal money, considered public money, and you want to have your due diligence in ensuring that you're complying with the requirements. The next piece is really a subcomponent of grants, which is really special populations, targeted special populations, and there's a variety of those sources. Your 330G, Migrant Health Funds, which of course the National Center for Farmworkers Health Association is significantly focused on, and which a lot of you are members of. And then there's the 330H, which is your Health Center for the Homeless, and then there's also 330I for public housing, primary care, and then there's also a 330 school-based. Now, some of you may receive straight 330, and some may receive 330G or H, or a combination of. So you can have a combination of those different things for the special population. And the focus here is that this special population does have a difference in how they need to be taken care of versus your regular population. Their needs are more important, and here it is critical for employees to ensure compliance, that they are ensuring that they are taking care of this population, special population, and meeting the requirements of that population, such as if you've got a population's language barrier, here it's really important to make sure you can communicate with those patients. Even how you see those patients, where are you seeing them, how are you taking care of them. So this population does have a special focus, and especially, of course, migrant and farm workers that have not only unique issues with their health, but also just restrictions and barriers on how they get the care. They are out in the field, typically working long hours. They don't have the ability to always come to you, those types of things. So this funding that's generated here focuses on meeting those needs for that special population. So with that, I'm going to give you a little bit of an idea of what the farm workers' revenue or the migrant funding looks like versus the patient volume, because here it's real critical for employees to understand that they need to identify the patient in the special population, and especially in the farm workers. So you'll see the federal funding that was received in 2013 versus 14. And what you'll see is that there was $35 million more received in 2014 versus 13. That's a 17% increase from the prior year in the federal 330 funding for the special population. Yet what you'll see is that 3.6% of the patients made up the increase from one year to the other. So even though the funding was 17%, the patient volume that was more than the prior year, only 3.6% of it were identified as migrant workers. So here, I can't reemphasize enough that patients need to be identified into the correct population groups in order to ensure that you are identifying them. So if you look at this, you've got 17% more funding, but your patient population based on what is projected as being reported is only 3.6%. The next sources of revenue, and again, if you do have a question, just like Christine said, please go ahead and put your hand up and we'll try to address those as you think of them. So we do have time to be able to do that, so I want to definitely do that. So the next source that we have is donations, and of course those donation sources come from fundraising events that your center may generate, individual donations, companies, employees. A lot of them have an employee program that they do where employees deduct out of their paychecks to the center. There's private foundations, and then of course a big one is in-kind donations. And the in-kind consists not only of supplies, direct relief, for example, Harry Schein, they all have programs that they'll give you supplies and items that are at no cost or medications. But there's also organizations that receive space at no cost, labor, volunteer doctors, nurses, or other types of staff, and then of course even services. So you may be in a situation where you get for your self-pay patients, they may be able to go to the hospital and get their radiology and lab at no cost. So those are in-kind donations, so things that you get as a community clinic for your patients that are benefits, and there's no cost to you, but it is considered a donation from a revenue source. The next one is incentives. There's been a significant amount of different incentives, both Medicaid, Medicare, electronic medical record, meaningful use. That's probably what you've heard it more referred to. That's paid per each provider, and that's paid and phased over 5 years. And that's to help the community health centers and medical providers implement an electronic medical record. So if your center is not taking advantage of those incentives, you definitely want to ensure that you are. There's also insurance companies that will give you quality improvement and performance improvement incentives. Managed care companies will have different incentives that they can give you, such as retaining a patient. So if you have a capitation environment and for taking good care of that patient from a customer service perspective, they'll give you a patient retention. And again, if you don't have these are things that you'll want to consider and discuss as your contracts come up. Because those are real significant income revenue sources to you, and they're outside of your PPS prospective payment system. So those are definitely new revenue sources for you that you want to benefit on. And then, of course, a big one is your patient-centered medical home. And here, some of the states, not all of them, have built-in incentives for you as you develop from your level 1 to level 3 patient-centered medical home. You get revenue per member per month in order to provide that. And of course, all of these things cost money, so taking advantage and making sure that your organization is receiving those funds to help offset those costs is real important. And then other revenue sources that typically we see in community health centers is what's called 340B pharmacy revenue. And here what it is the community health center and lookalike, FQHC and lookalike, has the ability to access 340B pricing, which is preferred private pricing that the government has set up with different pharmacy organizations. And the objective there is to ensure that patients have access to medication at a reasonable costs, or at much lower costs than what you have at your retail wholesale price. And what's happening is that as your patient, if you don't have a pharmacy yourself, your patient is going over across the street to Walmart or to Walgreens or to CVS or whatever, maybe your local pharmacy, and you're not really, they're not only are they not accessing that pricing, preferred pricing, but you're not really generating any revenue from them doing that. And you have the ability, this is in some states become very significant for community health centers. It's become sort of really just the revenue that has generated a bottom line for them to be turned from negative to positive, where they actually are entering into agreements with the different pharmacies in their community. So when the patient actually goes to one of those pharmacies, as long as they're tied to a patient that is a clinic patient, that patient receives the preferred pricing, and you as a community health center receive the difference between what the insurance company would have paid for that, less the dispensing fee, obviously, to the pharmacy. So it's a new revenue source for you that you may have not had before and may not be capturing, but it's very significant. And especially if you've got an HIV population, that definitely is significant. But from the patient's perspective, more than anything else, as you know, pharmaceuticals can be very expensive. So if you've got your farm worker that is trying to get medication at having to pay horrible costs versus being able to access and get this lower cost 340B pricing, that will be very significant. And then, of course, there's, you know, little revenue for medical records, parking fees for some of you, interest income, rental income that you may have, and other miscellaneous types of things. This is typically not a very big revenue source component of it, except for the 340B pricing piece of it. That can be very significant to the community center. So now let's just sort of look at the United States and the different revenue sources and what makes up the majority of those. And this is all of you combined. In 2013, your Medicaid revenue represented 39%, whereas your federal funding was 21%, and your state and local grant was 10%. So those are your three largest revenue sources. And you can see your self-pay is really 6%. It's a small percentage of your revenue because, again, here this is most of these patients a sliding fee and they're paying a small component, even though they represent a much larger portion of the population than the 6%. So I'm going to go through your Medicaid, your grant revenue, and your state because those, again, are the largest ones for you. But let's take a poll question before we do that and see if this is, Christina, can I turn it over to you, or would you like me to go ahead and read it, the poll question?
No, I can read it for you. If you would take a look at the chat feature for just a second, Lucy, while I do the poll question. But I'm going to go ahead and launch the poll question. So poll question number 1, does this help you understand how your CHC generates revenue, the different sources of the revenue and payment methods? So let me launch this question. If you would please, the poll is now open. I'm going to give you about 20 seconds to answer. So A, yes, B, no, or C, somewhat. A couple more seconds. Looks like about half of our participants have voted, so if you guys can put in your vote. Terrific. Lucy, so 100% of our participants said A, yes.
Wonderful. So we got a very clear understanding of the revenue and payment sources. And like I said, for most of you, this is not unfamiliar. This is all ground that you already know and are familiar with. But it sets a stage for us to understand just how there may be some other revenue sources that you may have not capitalized on and be able to benefit. And thank you, Christina, for pointing out the note on the chat box. Got it. Thank you. The next section we're going to go to is, did the Affordable Care Act have an impact on the ACA and the revenue cycle? And I'm going to say yes, yes, and yes, and yes, because this is so critical to the patient's experience and becoming even more critical, because now patients with coverage have access to more care than they did in the past. This creates a competitive environment for you. So patients that in the past didn't have a payer source, they now have a payer source. So your self-pay is being shifted into Medicaid, most primarily, and we'll see that in a subsequent slide, for those states that have expanded, or into a private insurance payer that they didn't have before. And of course, patients that did not have the health coverage before now can select where to go. They're getting more care than they have in the past, and of course this care is being sort of delayed, so some of them are really coming to you with a lot of issues. But the key is, are they coming to you? Because that's what we want to ensure as a community health center. They used to just come to you by default, and now they've got a payer source. They become attractive to other providers that may have not been willing to take those self-pay in the past. So real quick, if you look at the United States, that self-pay percentage by state, you can see that even though the average was 6% when we looked at the previous graph, but there are some states that are as high as 21%. And sort of the majority are anywhere between the 6 and the 14%. So this is quite significant for you. At the bottom of your slides at the end, I've also added for you and given you some state averages for each of the different other payers, your Medicaid and your Medicare, so you can sort of see what that looks like by state, since there is a variety of you represented from one side to the other. So let's look then at which ones are impacted the largest. Obviously, the states that have the Medicare expansion are the ones that have had a shift from your self-pay into a Medicaid. The ones that have not implemented, of course, those haven't just been of a large. And right now, there's 28 of them that have expanded. There are still 2 states that are in debate, and 21 states that have not implemented the expansion. And of course, that will impact the revenue. For the ones that have implemented, we've seen that in 2014, those clinics went from losses to being able to actually have little bottom line profits because of that significant change. So let's look at what it looked like now from a patient volume, the prior and the after to the ACA. So what you'll see is that the non or the underinsured decreased from 34.9% to 27.9%. There's an 18.8% shift, and that shift really went over to your Medicaid population. A significant portion of it, like we talked about, is the fact that not all the states converted or expanded, so it's not, really 100% of it. There's still quite a significant amount that are not, 21 of them. And then your private insurance is sort of interesting. It didn't increase as much. It's 1.5%, so we went from 14.1 of the population having private insurance to 15.3 of them having it after the ACA in 2014. So that still leaves us roughly 30 million remaining uninsured at the end of 2014 that would be eligible for assistance under the law. So there's still a lot of work to be done and a lot of care that needs to be taken care of. And of course, you are critical in delivering that care. The ACA has really had a large investment into the community health centers. There has been just a lot of money put in and allocated for this. And to give you an example of what that looks like, in 2013, the Primary Bureau of Health Center grant funding was $2.8 billion. In 2014, that grant funding was $3.2 billion. So you had an increase of $13 billion, or 377 million, in federal funding to support the ACA, to provide care for these patients. Now, keeping in mind, I shared with you earlier that 330, your migrant percentage of that 377 million, you actually got 17% of that population, for that increase. But if you recall, we only saw 3.6% of the patients that were increased from 2014 to 13. So out of the 1.1 million, the farm workers represented 3.6. Oh, that's what was reported, anticipated to be reported. So it's really, again, very critical to identify these patients correctly so that your revenue sources are tied with the patients that you are serving, because you don't want those revenue sources to disappear or dissipate for you. So overall, the addition of the ACA was $329 per patient seen. Each patient that you saw in 2014 under the ACA, you got additional $329 in federal funding for each patient. So that is very significant investment that has been put into the community clinics with the implementation of the ACA. So now we're going to go through and discuss the revenue cycle. Your revenue cycle really is the process of when a patient is scheduled to when the center actually receives the payment for that. It's as simple as thinking of it as just your financial circular system. And it's a system that ensures your paycheck. So it's a really important system. And, you know, a lot of us think, well, we're not financial. We're here to take care of patients, and that's true. But at the end of the day, we can't do it if we don't get a paycheck. And so this becomes really significant to the entire organization and to everyone involved in it. And so if I could put it into a different term for you, it's basically the revenue cycle is how long it takes for the system to circulate from the time the patient is seen to when the clinic actually receives payment. And the question is, how well are you managing that circulatory system? You know, you've got to basically ensure that you don't have any blockages in that system, and that is the critical criteria to ensure success for your community health center and then to ensure your paycheck. So we'll be focusing on that next. And the question really comes to is who's involved in the revenue cycle? A lot of times I'm not involved in that. I'm in the back office somewhere and I don't really have anything to do with that. Well, I'm here to tell you that everybody is involved in that. I mean, that is just very, very short-sighted to think that only the people that are taking care of the patients are involved. It's not. It's from the patient up front to the person that answers the phone, to the one that's determining the eligibility, to the one that's taking care of the patient, seeing them through the system, to the one basically credentialing the doctor so that they can see the patient, to depositing the money into your account, to processing your paycheck. So everybody's involved in this revenue cycle. So it's really sort of the lifeblood of the community health center. The patient comes in and everybody, that entire team, as I discussed before, including your IT, including anyone that's in dealing with contract, your maintenance, your cleaning crew, every single person is involved in that. And of course, if you're successful in ensuring that lifeblood is working well, then of course you've not only got happy employees, but you've also got happy patients, which is again the criteria of what we'll discuss with under the competitive ACA concept. So here's just a quick sample of that revenue cycle workflow. This is not an all-inclusive, but it just sort of gives you an idea that from the front office person, which includes, you know, taking the call, registering the patient, ensuring that they're eligible, or helping them with their self-pay, or identifying if they're eligible for any other type of coverage, to the clinical medical assistant, the lab person, the nurse, whoever it may be, all those people involved in that process, to the time that they actually go see the physician or the mid-level, to the billing. That entire process. And billing is not just submitting the claim, but collecting on it. It doesn't really help if we bill, but we are not able to collect, because we cannot receive a paycheck that says I owe you, you know. It's got to have money behind it. So at the end of the day, that entire cycle is very important. And of course, administration is critical in ensuring that all of this is occurring as it needs to. IT is critical in that. Your housekeeping maintenance is critical in that. And your accounting staff are critical in that. So every single person plays a role in this revenue cycle. So I want to give you an example of a best practice. And this is actually based on a real FQHC out here in California. And this practice I pointed out because they actually have less than a 30-day revenue cycle, which is probably one of the best ones I've seen. And as was previously said, I go to different clinics and evaluate them from one side of the states to the other. And this one really impressed me. I did write them up as a best practice because it really just they had it down, and they were doing it very well. And here I'm just going to go through a simple process for you. The revenue cycle here, the patient was scheduled and seen on the same day. The patient was, eligibility was checked before the patient was seen. The copay nominal fee was collected and posted at the time of the service. The provider closed out the encounter on the same day. The encounter and the scheduled patients were reconciled at the end of the day and sent to the billing company, or well, actually it was a billing in-house. And the encounter and the bill was submitted for payment the next morning. And payment was received within 30 days. So they actually were receiving and processing the entire process within 30 days, which is, again, one of those things that most of you, if you evaluate your revenue cycle, the average, what we'd say before, an average clinic, if you're doing 60 days, you're doing really well, but most are much more than that. So, here, when you think about our paychecks, we get paid every 15 days. So here, if your revenue cycle is more than 30 days, you can sort of see you getting paid before the clinic actually gets the money in the door. So being proactive as an employee to ensure that that revenue cycle is happening and everybody involved in it is critical, and it can be done because we do have this example of a best practice with an FQHC that is doing it. So the question really comes down to, and a lot of times we look at the revenue cycle, but we don't look at how it really impacts and consider the total patient experience, because at the end of the day, this is what's really, really important, because it's from the patient's perspective that we need to look at. So according to Jennifer Robinson, over 20 years ago, healthcare organizations have realized that providing exemplary medical care isn't enough. Basically, under the ACA, you're going to be forced to have to compete for these patients. So it's because from the patient's perspective, excellent medical attention is the least that the organization can offer them. That's what they're already expecting. So it's an expectation that the patient has. So it's everything else around it that becomes important. So here's something that's sort of interesting from the patients, again, from the revenue cycle impacting the patient's experience. Patient's experience was defined by Rail Institute as the sum of all interactions shaped by an organization's culture that influences patients' perception across the continuum of care. And I know that sounds like a lot of words, but if you really break them down, it is the organization's culture. When you walk in, do you have that feeling of a friendly environment? Do you have the feeling that you're being taken care of from one employee to the other? How's the handoff, how it goes? And healthcare leaders have realized that patient experience is very important. Actually, 93%, based on a survey that was done, said that patient experience is among the top 5 priorities for them. And it should be for you as a clinic as well, because you're competing for those patients that you may have not had to compete for before. But even if you weren't, we want to treat others just the way we want to be treated. So it's not a very novel concept. It's just being sensitive to that. So I'm going to ask the next set of slides really focuses on asking, what questions should you ask when you're evaluating your CMC's revenue cycle and the patient experience. And I tie that patient experience into revenue cycle because it's not just about getting the patient scheduled, seen, and the bill paid and out the door. It's more than that, and it's become more and more for community health centers than it has in the past. And really, when you think of this, you need to think of it in, how does my experience as a patient. So if I'm the patient, I'm put into the patient's shoes. Walking a mile in their shoes, how does it seem? All of us have been patients, so we can all relate to this at some point or other. And so that's what I'm going to ask that you do as you go through this next set here, or as you go through evaluating your community health center's revenue cycle and patient experiences. Put yourself in their shoes. And it's not only their shoes. One of the other things that's really critical is even how employees respond to one another. Patients are seeing that. You know, it's sort of like your kid. You know, how do they see mom and dad respond? You know, how do they see the interaction? The same thing with patients. When they see a respectful environment where your employees are treating each other with respect, then they also feel that same respect. So that's what we're going to do next, is go through that process. And we're going to walk some miles in their steps. So here, as a patient experience a revenue cycle, things that you should ask is time it takes before the phone is answered. All of us have been on the phone waiting for something and have been frustrated. Well, it's the same thing for that patient. How polite and empathetic is the staff when they answer that call? The time that it takes to schedule that appointment. The availability of the appointment times and days. And again, all of these components are so critical, because when you look at it, from the time it takes to answer that phone to the availability is a variety of different people involved, from not only your receptionist answering the phone, but you know, how your policies on same-day appointments and availability and scheduling, all those things matter. You know, do you have the doctor behind you saying, no, don't schedule that patient, no, I don't want to see that patient? Or are they taking care of the patients and letting the people up front take care of the scheduling component? Or is your scheduling centralized, where the front people up front aren't even dealing with that, they're just dealing with the patients and not being distracted by that? So how you set up is real critical in answering all of these questions, and all of you play that important part of that. So let's ask some more questions here. The number of questions that are asked during the scheduling process. I think all of us have been sort of frustrated as we go through and have to answer 100 million questions. And of course, in the FQHC environment, we do have to collect a lot of data that maybe you wouldn't in a private doctor's involvement. But can we streamline it so we're not asking them to answer it in 4 different forms in 4 different ways? It's real critical to see that we've got that process down to minimizing the questions that we need to ask, so we collect the data for the UDS and so on as needed to ensure our compliance with our grant funding, but that we're not overburdening the patient. If the patient receives a reminder call, I mean, I love it when I get a call from, it doesn't matter what type of appointment I have, to just tell me that, remind me that the call's there. That also, of course, helps your no-shows, which again will help your operations run smoother and have an ability to flow out the workflow for your employees, and increase revenue, obviously. And if patients are told or able to provide the required documentation before the appointment. I've actually called an FQHC before, and I asked them if I could please have the paperwork ahead of time. I was taking my mom and dad there. I'm a true believer and a consumer of community health centers because I know the quality of care that's provided. And this clinic, unfortunately, could not fax over or email me their documentation ahead of time. There would have been no reason not to, but they just didn't have the processes in place to do it. A very simple, easy fix to accomplish, and to ensure that when the patient arrives, your registration process can go much quicker, much smoother. So more questions. How many duplicate questions the patient is asked upon arriving at the appointment? We talked about that already in detail. But a lot of times what the experience is not only does one person ask the question, but then you'll get somebody else that asks the same question the patient's already answered. So ensuring that you're coordinating, working well with what you're going to ask the patient is really critical. What additional paperwork do they have to complete? The accuracy of registration information, real critical. Again, if they have that information up front, if the patient's able to register ahead of time. Now, some of you have the ability to register online and those types of things. And as technology changes, of course, these processes are also changing and allowing you to be more efficient and effective. But what we find is that community clinics don't always take advantage of that technology. And the new population, they want to do it on an app. They want to do it on their phone. They want to make an appointment on their phone. They want to complete that paperwork right there. And so we have to keep up with that in order to not frustrate them too, and in order to compete to keep them as patients. And then revenue sources, the insurance information verified before their services are provided. Again, critical. You want to make sure that those patients with the appropriate coverage for you to ensure that the services you provide turn into a payment source is done ahead of time if possible, or done at the time of the service. If you do it ahead of time, obviously, if there's any issues, you're able to address it much better with the patient, and you're able to call them to ensure that they have other sources or bring other information or update information at the time of service versus doing it after the fact, because that's going to add to the revenue cycle time. And here, I'm going to bring up one thing here for insurance verification. One of the things that we don't do in community health centers very well is look to see if the patient received any retro coverage for services that they've had in the past. Typically in a hospital environment, you do see that because they're usually large dollars and people become eligible and have coverage that they didn't even realize. And meantime, they went into, got the services, went in, got taken care of, and they did have a certain source of coverage. So they could have been self-pay, but they could have received Medicaid, and you don't know about it because they got it notified after the fact. So looking and determining eligibility, there are some services out there now that are focusing and targeting FQHCs, just like they did the hospitals, to do retro Medicaid certification. And that, again, a lot of them do it on a contingency basis. And there's not a lot of companies out there, but they do it on a contingency basis. So that, again, is something for you to think about if you don't have that in place, if you don't have the ability to do that verification right up front. But even if you do, it's the retro certification that they could have received coverage for that you don't know about now, and you still have them as self-pay, and you could have billed Medicaid for it. Then the question comes again, how long does the patient have to wait before they're called? This is so critical. Again, none of us like to wait. So how long they're waiting is significant. That's a very important piece because, again, in a competitive environment, that patient has options. If you're not going to take care of them timely or what they perceive as timely, they can go somewhere else. How kind, patient, and respectful the staff are to the patient and to each other. I can't emphasize enough each other because patients are looking and seeing that. How long the patient has to wait for that provider. And again, here, the critical, we do know things happen. We know critical that providers do get backlogged. All kinds of things could have happened. But it's really important, is the patient being told the provider's running late? I was at one site, and they actually had each of the providers listed on a live screen that said a provider is running 5 minutes late, provider is running 10 minutes late, and it was being updated continually. And I can tell you, when I first got in, the appointment I had, the provider was running 30 minutes late. And I thought, okay. But it kept getting updated, and that 30 minutes actually went by so quickly, I didn't feel like it was 30 minutes because it was being updated continually. And again, you may not have the ability to do that, but you do have the ability for staff to be able to verbally say to the patient, the doctor is running a little late, we apologize for having to wait, but we'll try to get you in as quickly as possible. And then when 5-10 minutes has gone by, mention it again, because if there is communication and interaction with the patient, they do feel that something's happening. The time doesn't go by as slowly as just sitting there not knowing what's happening. How the provider makes the patient feel. This is very critical. There was a study done from the patient's perspective on how long the doctor spent with them. And the study was done where the patient actually was put in the room, and they did it in a hospital environment, they did it in a clinic environment. In the hospital environment, the patient that was waiting for the doctor, when the doctor came in and sat on the bed with the patient, and they all spent 5 minutes. They only spent 5 minutes, each single provider. But when they did the survey, the patients that had the doctor sit on the bed with them actually felt that the patient had spent more time with them. And the same thing with the clinic. When they came into the doctor's office, the doctor that actually touched them and put the little microphone on them, did a few things to them, actually communicated with them, depending on that communication, they felt that the doctor provided more information to them than the doctors that went into the room, for example, but did not touch the patient or did not have a direct communication with them in a much closer, intimate relationship. So here's a very interesting one. How does that provider make that patient feel? If the medical information is well explained to the patient, this is again culturally and linguistically sensitive. I mean, is the patient being able to understand what's being communicated to them? If the coordination of care is smooth for the follow-up, so they need additional services and that happens smoothly, this again is important from the patient's perspective. And if you think the patient isn't impacted by it, they sure are. Having being a patient on the other side, and again I remind you, walking in the shoes, I mean if you think about it, I'm a little farmer, I come in and I don't know anything about healthcare and you tell me I need to go get a X-ray. And how smooth that transaction happens and how it helps me to go to that next provider is significant because I really don't know. Not only am I scared because, I'm going to have to go have additional testing done, but I really don't have the experience of knowing how that process works and going into a different environment and whether that environment is able to communicate with me in the language that I can communicate and understand in. So very critical on that smooth transition. If the chart and the coding at the end of the visit is closed and done by the provider, and again here a lot of you with electronic medical records have such a significant ability to be able to improve on this. And if you've got policies and procedures or requirements that, chart does have to be closed within that time frame. A lot of them are 24 hours, chart has to be closed. But if you think of it from the doctor's perspective, how can they remember all the different patients at the end of the day? If you're doing it right at the end of the close of the visit, it's definitely much easier to remember what's happening and what diagnosis is needed for that patient than at the end. So building that in and ensuring that that's part of your process of your revenue cycle is very significant. So programming a lot of these codes and having your bills drop with those is significant, not making the provider having to do more than they need to. If you've got a certain CPT code that always comes with a certain diagnosis or comes with requires a certain modifier, whatever it may be, having those built in so that that's not just being done at the end. And it can even be if you build your encounter properly when you're programming your electronic medical record, depending on the level of the things that you do and that your provider's marking as being done, that should automatically tell you if that CPT code is a 99213 or 4 or 5, based on that level. And then again, you've got documentation to support all of that billing code that you're doing. If the patient's visits and encounters are reconciled daily, I can't tell you how many do not know or reconcile the number of patients that were seen that day with the number of encounters that drop. It's almost as if, well, the patient scheduling, that's one department, and the billing piece of it is another department. Those two should be reconciled. We need to make sure we've got all of those. In an electronic environment, you've got open encounters that you're able to look at. You're able to see, here's the scheduled patients, run reports and see, what are those open patients? Which patients did we not have encounters for? Why didn't we have encounters? Are there no-shows? Are they being followed up on? Or is it because just we didn't actually do the documentation and need to do it? So those need to be reconciled in order to ensure your revenue cycle is tight. If the patient payments were made at the time of registration, there's many ways to ask for that revenue. A lot of times, again, employees have to be sensitive to the patients and to their needs. And of course, we are serving the underserved, so doing it in a respectful way is important. But posting those payments at the time of service, what I highly encourage for community health centers is have a notice right up front in your registration area that says you're required, when you make payment, you are required to receive a receipt from our system. If you do not receive one, ensure that you contact administration at such and such a number. Because what happens is you don't want the patient to make a payment, and in this population, a lot of times is cash, and you do not know if you really got all the cash you should have got. You don't even know if it got posted correctly or to the right account. So by having the patient accountable for it, you'd be surprised at how that comes to the surface. So if the employee pockets the money and doesn't give the patient a receipt, you don't know if the patient ever collected it or didn't, if it was ever collected. Unless, of course, it's posted at the time of the service and the patient receives that receipt from the system, so you have something to reconcile to, and then ensure that that amount of money is what got put into the bank. And that all your system payments are reconciled with the deposits. That's exactly what I was referring to when I'm saying, you received a certain amount, that certain amount go back into your bank account, and all those reconciled. If payment arrangements are made before patient departs, once the patient has left, it's much harder to make payment arrangements than it is after before they leave. I mean, it's like anything else. You come in sick, you're willing to get better, and once you're better, then you don't have as high of an incentive to try to make those arrangements. So you want to make sure that you have a mechanism. So if the patient can't pay, how can we make arrangements? Maybe they can only pay $1 a month. Maybe they can prepay some or pre-print some checks for you, and sign those checks with posted dates for future that you can take care of. Or maybe they've got other mechanisms, credit cards or other abilities to make those payments. If patient was reminded during the appointment time of their balance or any payments that they are expected to have, again, that's very crucial, and how it's handled. I always tell employees and staff, when you ask that for those funds, put it in perspective of, we want to be able to take care of you next time you need us, and for us to do that, we just ask that you pay your small component of it, or as much as you can, because if we don't receive those payments, then we can't take care of you, or can't be here necessarily guaranteed to be here tomorrow to take care of you. So every little bit helps. Some clinics, I've even seen them say, well, give us a donation, be it a $1 donation, $2 donation, whatever it is, even if they can't pay a certain piece, when it's tied to certain procedures or things that are done for them. And then, of course, ensuring that your CPT, ICD-9 modifiers, codes are maintained and current. Of course, we've got ICD-10 coming, and that is going to change your world. You want to make sure that you are up to date, and your electronic medical record provider, your billing practice management system, has the ability to be able to update and ensure that you're going to have all these new codes for 2015. And that is just around the corner, and it's a significant amount of increase of codes and modifiers that are going to be added. So getting ready for that is very important. Maintaining those current is very significant, and that is definitely creeping up, and it'll have a significant impact on your revenue cycle as we hit the end of the year here. So walking in someone else's shoes, not only walking in the patient's shoes, but walking in your co-workers' shoes, understanding what they're having to go through on the other side when they're trying to collect for those services that you did as the provider, but you don't have all the information because the registration person didn't get it all correct. So how do we do that? Making sure the claim goes through an edit error list and a pay eligibility before submitting it. What does it help for us to submit a claim that isn't accurate, that we know isn't going to get paid? That is just extending the revenue cycle. So making sure that you have in your system, in your claims process, does the company that processes your claims, do they have edits to ensure and to screen for a lot of those errors before you even submit the claim? And are we fixing those? And the other question that always comes in is, are we fixing it at the claim level, or are we fixing it at the source level? So if the source level is you've got your computer set up with the wrong code and it gets rejected when it goes through the claim edit process, but we never fix it at the computer level, that error is happening every time. So you've got to look at every area, see the source, and then try to fix the problem at its source so it doesn't keep happening. So rejected claims, look at those immediately. Look at what the reasons for those are so that you can fix the source problems like we talked about. And our claims submitted daily, I can tell you that so many clinics only submit twice a month. You know, I say if you want a best practice in a revenue cycle that ties a little closer with our paychecks, it needs to be done daily. Whatever was done daily gets submitted daily. Then your revenue stream is going to come in and your cash flow is going to be much better. And also you're going to identify problems sooner. You're not going to identify them when it's too late, when your claims are way too late to submit or issues are too late. And if you've got a problem, you're going to identify that problem to be able to fix it much quicker as well. So a best practice for your revenue cycle is submitting daily. So you don't have as many to submit. That's great. The workload is much, much easier for your staff. So at the end of the day, when you've got your billing collection staff, the first hour they're submitting the claims from the prior day, the remainder 7 hours they're doing follow-up and reviewing any rejected claims and any errors and following up. That's how your revenue cycle should be focused for your billing and collection people. An hour should be focused, first hour to 2 should be their billing, submitting the claims, and the remainder 6 to 7 hours should be focused on actually reviewing, collecting. I always say they shouldn't be called billers, they should be called collectors, because billing is a very small component of the actual process that they should be doing. And when you've got your billing office only focused on submitting bills and not actually on collecting the bills, that becomes an issue for you in your revenue cycle. If third-party payers are posted timely, this again is very important. A lot of times the payments are coming in and they're sitting and they're not getting posted to the patient's account or to your insurance payer's account, you know, to the payer, so you can do a secondary billing. So if there's a delay and your posting of your payments are delayed, then your secondary billing is being delayed as well, increasing that revenue cycle. So I would say a best practice is definitely getting that payment posted within the 2 days, reconciling that payment through that system to what gets deposited into your bank. And of course, a lot of those systems do allow and have the ability for you to post electronically. So of course, you want to take advantage of everything you can on those. And we talked about the secondary crossover claims, the importance of submitting those timely. In the states where you do have a PPS rate where you're billing a secondary, sometimes even 3 parties, could be 3 times before you actually get your full prospective payment system payment from the state, you'll want to get those done very timely so you can submit immediately. So we continue. There's a lot of questions. Like I said, it impacts every single person and every single process in your organization. And this impacts the patient, because when there's issues and those aren't clean, the patient does end up getting stuck in the middle of a lot of those. An example, you don't check eligibility ahead of time. The patient then 2 months later gets notice or gets a statement, so they're upset. Where we had done our piece up front and that was all clean up front, you wouldn't have that issue with the patient knowing up front that they didn't have that coverage. And it's amazing what patients don't know, even though we think they should know. If open encounters are monitored and closed out within the 24 hours, real important. I can tell you when I go in and I ask clinics, tell me how many days in open encounters you have or how many dollars. They don't know. They say, oh, well, we think we can run a report like that, but we don't know. And you should know. That should be something that you really need to know. We've got X amount of dollars and X amount of claims every day open that can't be billed, and determine what's the reason for that. There is typically some reason, but making sure that that is being monitored is important. If your denied claims are researched and corrected and submitted daily, that's again very critical for your billing post staff. They're submitting the claims in the morning, then they're working the collection, the denials immediately and resubmitting, and not waiting, for months or sitting in the mail. I've seen it where there's a mailbox. It goes in there. It's this big box of stuff, and all the denials are in there, and they've got thousands and thousands of claims and dollars stuck in there. And as we get bigger, the bigger the volume is as well. So more important again in correcting that and correcting it at source so it doesn't continue to happen and become an uncontrollable animal for you. If unpaid claims are followed up, if a claim hasn't been paid and that payer is all electronic and typically they should be paying within 15 to 20 days, you've got to follow up on that. Real critical. A lot of times people think, well, we don't have to follow up on claims until it's been 60 days. You don't want to have a revenue cycle at 60 days because we're not getting paid on our paychecks within 60 days. If all the providers are properly credentialed and contracted before seeing patients, very critical. Again, does impact the revenue cycle impacts every single person that works at that clinic, and the credentialing is very important. You can't get paid if you don't have those providers credentialed appropriately. If contracts are in place to ensure the majority of the patients' sources are contracted so you actually have revenues for those patients is critical again. And if you've got the authorizations obtained for any procedures that are required, if you don't have those authorizations for the payer sources that require it, you're going to, again, have denied payments. Looking at some more of these things, the things that you need to do, your AR aging report has got to be monitored weekly. Staff and providers must be continually trained, and the denied, rejected claims shared with them. If they don't know what's happening, how can they actually fix it? If the revenue cycle is part of your organization's QI plan, I can tell you I've not yet seen one revenue cycle patient experience being tied to that QI. I have seen it from a clinical, but not from a financial piece of it. Usually the QI program doesn't even include the financial people, and it should. A QI plan should be your entire organization. And if the staff are trained on who collects the patient up front, collecting from the patient up front and following up on those unpaid accounts, if the patients are educated on the expectation of the organization, and if the patient is screened up front for any other coverage. Again, our goal is to ensure that we not only take care of their physical needs, but their financial ability to take care of that as well is significant. So let's go to our next polling question, because that was a lot of material that we covered. So Christina, can I turn it over to you?
Absolutely. Let me get the poll launched. So the question is, do you think you currently have a role in the revenue cycle and patient experience at your CHC? So please make your vote. A, yes, B, no, or C, don't know. We'll leave the poll question open for a few more seconds. We have about 40% of you have voted. So go ahead and mark your answer, please. Okay, Lucy, it looks like 100% have said yes.
Oh, that's wonderful. So this is something that community clinics are being and having to focus on. So that is excellent. I don't know if some of you need to stretch your legs a little bit. We have been going for a little while. But what I'm going to do next is go through some sample cost revenue mismanagement costs, what it actually looks like when you don't have these things in place. But I wanted to, before I do that, I wanted to see if there were any questions at this point. Maybe we could just open up and see if there's any questions, because we are covering quite a lot of material, and if there's anything at this point that you may have that I could address for you, we'd like to do that, and then that'll give us a little bit of time to stretch our legs as well if you need to, and then we'll continue. So Christina, could we maybe open?
I've not had any questions come through the chat, but please feel free and use that chat feature to send any questions, especially at this time, or if you'd like to ask Lucy something, I think that we have some time to do that as well. No questions so far,
No
Lucy?
questions. Okay, great. Okay, then in that case, we will continue. It is Friday afternoon, and for some of you, almost home time here, so let's continue here. What I'm going to discuss with you and give you some examples now is just what that mismanagement looks like. So, you know, these are powerful tools that you can share with not only your staff, but with your coworkers. So when people don't do something, they can see what it actually looks like or costs. So from a patient's claim, when it's not clean, when it's not submitted the first time and paid correctly, it costs about $25 per claim to refile, and it adds about 45 more days to the revenue cycle. So you can see how significant that is and how costly that is to the organization. So we want to try to ensure that that claim is clean and sent out, and that you've got pieces in place to ensure that. And then every copay or patient responsibility that's not collected at the time of service, this one I think you'll find very interesting. It costs about $30 to collect at the back end of that, and it adds about 75 days to the revenue cycle. So when you think about a nominal fee being, some of you, your nominal fee is less than $30, and here now it costs the organization, if we don't collect that amount up front, or at least a portion of it, $30 afterwards, and it extends the revenue cycle by 71 days. So this is some significant dollars. If you start putting that into perspective, it's, you know, significant for the organization. The other thing is that every patient that a community health center loses costs them about $500 to $1,000 in lost revenue. If you remember, I shared with you that the average is about 3 to 4 visits for an adult, and if you think that patient's going to come in as at least 5 potential new patients, your revenue loss for every patient could be anywhere between $2,000 and $5,000 in revenue. And this is based on some marketing information that's been out there. So it is significant to you. So, you know, if you're going to spend money to market and to put advertisements out and to send people out to outreach, and then we don't take care of them and keep them in the community clinic, this is the cost and the potential revenue that you're losing. So if you're spending it on one end in marketing and then losing it on the other end, that's significant. And every patient that has a bad or poor experience tells 5 other potential patients. And if they have a good experience, positive one, it takes 12 positive experiences to make up for 1 resolved negative experience. And I'm going to share with you a real experience that happened actually this week with an FQHC, and it was a CEO. A patient was coming down the elevator, and the CEO happened to be in the elevator with the patient and with another employee. And the patient was very upset. And the employee was making some little funny jokes, and then they got off a certain floor, and the CEO stayed on the elevator with the patient. And after the employee had left, the CEO asked the patient, "How did we fail you today?" And the patient was sort of shocked, you know, sort of surprised with the comment, and she asked the patient to step into her office and to chat with her, and she heard what the issue was. And bottom line is that patient had just been turned away, and they had not only called ahead previously and scheduled an appointment, they had to take 3 trains and 1 bus to get there, and they had come specifically to the clinic, and they had this was a payer. They had payer source, so it wasn't a self-pay patient, and they had just been absolutely treated horribly. So that experiences are happening, and if the CEO had not intervened and asked that question, of course she took care of that immediately and said, "You will be seen today, you may have to wait a little bit, but we will take care of you and we apologize." So we went from having a very negative experience to basically having a positive experience, and that patient probably told at least 12 other people that they know and their family members about that experience. Now, it could have also been that same conversation with a very positive outcome to that clinic. So this is very significant that those patients have those experiences. So when I was talking with the CEO, one of the things they're going to do is tie and have a patient survey for every single patient after their experience. in order to try to diffuse and resolve this, because it doesn't help them to spend money on marketing and outreach people and then have these types of experiences when the patient comes in that loses. And it was all about, at the end of the day, a lack of communication between the staff and how their processes are set up. So one of the things that I've given you here is sort of a list of some of the measurement and reports used to monitor the revenue cycle. All of you probably have these reports in some form or fashion, but again, you may not be looking at them and using them in the concept of the revenue cycle, and that's what I sort of want to focus for you here, is that each one of these is important and helps you with that revenue cycle. And again, I'm not going to read the list for you, but this is a significant list of items that a lot of you may be looking at in one area and looking at it just as part of the accounting or billing department's responsibility or the provider productivity side, and not looking at it as the whole cycle. And I think if you start training employees and showing them that they are part of that revenue cycle, and of course a lot of you did respond that you are part of it, but do you see the whole picture? Do you see how from scheduling that patient to how you get your paycheck and how your piece of it is so significant? I think it'll allow employees to hold each other more accountable. And then these reports, that they're not just pieces of information with some great data that nobody does anything about, but that those are actually reports that are looked at. You should know how much your accounts, how many days you actually have in receivables by each payer. How long is it taking those payers to pay? Is there an issue with those payers? And if so, what can we do to fix that issue? I can tell you from my past hospital experience, we would have the patient call the insurance company, and that was very successful, because the insurance company may not listen to the provider, but they sure listen to the patient when the patient calls and complains. So your patient can be your highest advocate to ensure that payment occurs. So using that is important. Know your cost of collections. It's important to know how much it actually costs you to collect that dollar, because a lot of times we spend more money to collect than what the money is actually worth. So you don't want to end up spending $30 to collect a $20 amount that isn't always efficient. And here's a great example of, actually, it was a billing office staff person, and I was walking through the revenue cycle with him on his little piece, and I asked him, so what do you do? How do you collect on these? He says, well, I resubmit the claim. When I get a rejection, I resubmit the claim, and so I said, okay, let's look at one claim, because again, that's the only answer he gave me. So I had him pull up a patient, and he had resubmitted the thing 5 times, still no payment, because he never fixed the issue. So resubmitting it isn't the answer. It's really knowing what the issue was to fix the issue, and then of course fixing it permanently, not just at that claim level, and then making sure you get paid. So having your staff understand that component is very important. The other thing that I think has been very successful is for the receptionist staff to also have experience with how the bills get submitted and paid, because a lot of times they don't know how important their front piece is to the back end piece. And so one area what we actually did in this organization, we had a program where they did cross-training. They actually got to spend 6 months in each other's shoes, and not only did they build a lot of respect for each other, but the improvement of errors and why they were collecting the information suddenly became real to the staff at the front end, and there was much less finger pointing. And all of this started because the billing would blame the reception people, or reception people would blame the doctors. The doctors go, well, I've done my part, I don't know what else you want me to do. It was just sort of a finger pointing. And once the reception's front people and the back end people understood their jobs by this cross-training 6-month program in each other's shoes. And it was very interesting to see how now the organization also strengthened its assets. It had much more resources. So if it needed to include someone up front because the patient volume went up, they could pull right from their billing department, or vice versa. If the falling behind on their billing in some issue collection, and the staff up front were slow. They had the ability to do that. It's because they were completely cross-trained. So that's, again, a lot of creative things that you can do, but having the staff understand and walk in each other's shoes is real critical. So the next thing I want to do here, changing a little bit of gears, but giving you a little bit of background on the federal grant funding and the revenue cycle. There is definitely program requirements that are impacted by this revenue cycle, and so we're going to go through those. The sliding fee being the most important one, of course, program requirement number 7. You're all familiar with it, and the new PIN and the requirements there. But here, again, you can sort of see how not getting that information up front or not getting the right information and determining that patient up front impacts that sliding fee. So your policies and procedures that you have for your sliding fee also need to be practical. I mean, that's not only part of the PIN requirement, and again, that PIN's got a lot of pieces in it, and we did a training on that one a couple months ago for you guys, but that's a very important component of your revenue cycle piece. Program requirement number 12, your financial management and control policies. Here, the program requirement, it requires you to have internal controls and be financially viable. Well, if you don't have these pieces in your revenue cycle, or you're not reconciling your patients that you've seen to the revenue that's generated and submitted for payment, or your payments are posted, there aren't those controls in place, so then you're not in compliance with those program requirement number 12. So that's a very important one. And again, you can see how everything we've discussed will tie back to one of these program requirements. Your billing and collections, we've talked heavily about that one. Of course, you've got to have a system in place to bill and collect for it on that program requirement. And the revenue cycle is critical to it, and ensuring that you're being effective and efficient. Your budget, again, you think, well, what budget doesn't have much to do with it, but it does. If you're not able to pay your employees, your vendors, you're not able to meet your budget. So your revenue cycle is what allows you to do that and to accomplish it. And then, of course, program requirement number 15, which is your program data and reporting systems that you have to have in place. And, you know, a lot of times when I go in and look at this program requirement for community clinics, they have the pieces in place, and it's almost like too much data. They have so much information, but it doesn't mean or do a lot for them. And, you know, I get asked a lot is, you know, do you have a dashboard that you can share with us what it looks like, and so on. And I always say, you know, the information in the dashboard needs to be what you important to you. Taking someone else's is irrelevant, because what may be important to them and the issues that they're having that they're trying to measure and monitor may not be the same ones that you need to. But that list of reports and monitoring things that I gave you, you know, those are great examples of some of the items that you can include in that dashboard. And I always say, you know, for data is great, but you've got to put it into perspective. So graphing information and seeing where you're at versus where you are now, you know, so benchmarking it against yourself is probably the best thing that you do, so you can see if there's improvement. And building and tying that into your quality improvement program. You know, everybody should be involved in your QI program, and they need to understand the component of it. A lot of times the issue is that you've got a QI director or staff, and they always think it's just clinical and it doesn't tie to all of these things. But the health of the organization, the patient perspective, they expect you to be good at providing quality care. We've already determined that from some of the studies that have been done out there, but it's all the other things that need to go in line with that. So these program requirement number 15, having that data system in place, is not just having it, but being able to analyze that data and making some sense out of that data. All right, and now the bonus question. We're getting close to the end here, so I'm going to go through this one here. What I've done here for you is identified a maximum revenue cycle impact on your patient experience and and how to protect your future patient lifetime revenue potential. Because all of you are trying to get more patients. You're trying to improve your numbers. You're trying to improve your performance on the revenue side, and you do it by tying it to your future patients and your revenue cycle by keeping the ones you do have and letting them be your marketing tool. So let's go through this in relationship to that and how to outline and think of some of the community things that you can do. You can adopt and approved patient experience initiative that's tied to the revenue cycle. That, I think, if I would probably do a survey on this question, the percentage of how many of you have it tied to that is probably much smaller, though you may be doing it indirectly. You don't actually have a patient experience initiative that's tied to that revenue cycle. You've got to educate not only your employees but your patients in light of that revenue cycle and the impact on the outcome. They need to understand how it impacts them. Create an environment that fosters patient loyalty as a critical outcome. We talked about that CEO where we're going to implement them doing a patient survey right at the end of every visit. That way they're getting feedback timely. She's going to know and be able to diffuse those situations just like she did that patient that was going down the elevator right away and turn a negative into a positive. Design a patient-centered revenue cycle process that is focused on customer service excellence and resolving all the patient's concerns. And again, resolving all the patient's concerns. I know you can never resolve all of them, but again, it's within the scope of what you can do because you don't want to let things fester. So your cycle needs to have a mechanism to do that. That patient survey at the end is definitely an important one. It also allows your employees to know, I'm going to be measured by this patient. They're my customer. They're the ones I need to keep happy. They're my paycheck. They need to see the patients as their paychecks. So integrating patient survey completion within the patient revenue cycle communication process is what we talked about. And then utilizing technology to support the customer services and this call center's personal training and establishing those goals. And then ensuring that your third-party services providers are fully supporting of your mission and initiative to enhance the patient experience. And again, third parties can have a very significant impact there, and you can get revenue sources from them. If you've got capitation environment, have an incentive payment that's tied to every patient that you keep. I mean, that's really, patient retention is very important, not only to that managed care organization, but to you as well. Have them pay you for every patient. Do just like they pay you a PM for that, you have a payment system for that. I'm in the process right now of negotiating with three different insurance companies, exactly that setup for a clinic. So it's very much doable, and it's very much something the managed care organizations want. And then, of course, explore social media sites to communicate your message. This new generation, they speak in a different language than we do, and we need to make sure we're communicating with them on that. So I'm going to open up to questions if you've got any, or if Christina has any in the chat box. If not, we did have one that was asked prior to our talk, and that was from Maria, so I can answer that one. But Christina, do you have any in the chat box?
I have not received any in the chat box.
Okay, whoa, either I'm doing a great job or there's no questions. So I did want to address Maria's question. This is the additional slide that was added. I want to thank you for your time here, but this was a slide that was asked about whether you can bill for CHWs. And so for those of you that are not familiar with that, it's community health workers. Also has other terms that are used for it. And in certain states you can. In Texas, the question came from Maria in Texas. I did connect with the Texas Department of Health and Human Services and their CHW training. And unfortunately, in Texas, they do not have anything in place to pay for those services. This chart shows you which of the states actually have financial reimbursement for it, and you can see that Texas is not one of those. But I did want to give you the telephone number for the Department of Health and Human Services in Texas that deals with the CHW in case you've got any other questions. The number there is 512-776-2570, and Monica is a wonderful, helpful lady if you've got any questions there. But for some of you that are in these other states that may have some reimbursement, you'll want to make sure that you are taking advantage of those. There are CPT codes 98960, 6162 that allow you to bill for some of those services, but you obviously have to be in a state that has set that up. But what I do recommend or suggest as an additional revenue source for those of you that do not have states that have incorporated that into their reimbursement for Medicaid, is contact your insurance companies, have them start paying you for some of that, because that is, something that is a benefit not only to the patient, but that from a quality of care and a follow-up and integrated service for the patient, a continuum of care, that's important, and it can cost and save the organization, the managed care organization, costs. So you'll want to negotiate with them to try to get some of that revenue. And that's the end of the questions that we had. So I thank you again so much for your time. The additional slides that are here are just really for interest purposes, and I'll let you enjoy them at your leisure. They really focus on the top revenue states that are there, and what the Affordable Care Act looks like, and some of the impact and barriers that patients still have. So thank you very much. With that, I'll turn that over to Christina.
Thank you, Lucy, and I'll remind everyone to please fill out your evaluation when you receive it via email, and also to register for some additional webcasts that NCFH will be hosting this month at ncfh.org. Thank you, Lucy. That was wonderful information.
Thank you, and hopefully it was helpful, and happy Friday weekend to all of you, and thank you so much. Goodbye.
Thank you.
Bye-bye.